The journalist attacked the elderly black woman on live television without knowing she had revolutionized cancer treatment and saved more lives than any doctor in the city's history. 79-year-old Dr. Evelyn Carter sat in the cramped waiting area of Channel 8 News on that rainy Tuesday morning in November, wearing a simple navy blue dress that she had purchased from a discount store 20 years earlier and carrying a worn leather briefcase that contained documents chronicling 5 decades of groundbreaking medical research. To 32-year-old investigative reporter Michael Harrison, she looked like exactly the kind of outdated, irrelevant protester that his exposé on healthcare waste was designed to discredit. Dr. Carter had arrived at the television station 45 minutes early for her scheduled interview, a habit developed during her years as chief of oncology at Metropolitan General Hospital, when punctuality could mean the difference between life and death, for patients whose treatment schedules could not accommodate delays. She had agreed to appear on Harrison's morning show to defend the community health clinic that served the city's poorest neighborhoods, unaware that his interview was actually an ambush designed to embarrass advocates for what he considered unnecessary social spending. The community health clinic that Dr. Carter had founded in 1987 represented the culmination of a lifetime dedicated to ensuring that quality medical care reached patients regardless of their economic circumstances or insurance status. Located in the heart of the city's most underserved district, the clinic provided everything from basic primary care to specialized cancer screenings, operating on a combination of federal grants, private donations, and volunteer services from retired medical professionals who shared Dr. Carter's commitment to healthcare equity. Michael Harrison's investigation into what he termed wasteful healthcare spending had been prompted by budget documents showing that the city allocated nearly $2 million annually to support community health initiatives, including substantial funding for Dr. Carter's clinic. His research had focused on cost-per-patient metrics and administrative overhead expenses, but it had not included any analysis of health outcomes, mortality prevention, or the long-term economic benefits of early intervention and preventive care. The fundamental disconnect between Harrison's perspective and Dr. Carter's reality reflected broader cultural and generational differences about the purpose and value of healthcare systems. Harrison, who had graduated from journalism school with a focus on investigative reporting and government accountability, approached healthcare spending as a fiscal issue that could be evaluated through simple cost-benefit analysis. Dr. Carter, who had spent 53 years practicing medicine in urban communities, understood healthcare as a complex ecosystem where investment in prevention and early treatment created savings that extended far beyond immediate budget calculations. Dr. Carter's journey from a sharecropper's daughter in rural Mississippi to one of the nation's most respected oncologists had been shaped by her understanding that medical knowledge meant nothing if it couldn't reach the people who needed it most. Born in 1944 to parents who worked cotton fields and had never attended school themselves, she had learned to read by studying her grandmother's Bible and had developed her interest in science by helping her mother prepare herbal remedies for neighbors who couldn't afford doctors. The transformation of young Evelyn from a barefoot child picking cotton to Dr. Evelyn Carter, the first black woman to complete an oncology residency at Johns Hopkins University, had required not only exceptional academic achievement, but also the kind of perseverance and determination that came from understanding that education was both a privilege and a responsibility. Every scholarship she received, every barrier she overcame, and every professional milestone she achieved was understood as an opportunity to expand access to medical care for communities that had been systematically excluded from quality health care. The cancer research that had established Dr. Carter's international reputation began during her residency in the late 1960s, when she noticed that black patients with certain types of tumors had significantly different survival rates than their white counterparts, even when receiving identical treatments. Her investigation into these disparities led to groundbreaking discoveries about genetic variations in cancer metabolism, research that would eventually result in personalized treatment protocols that improved survival rates for patients of all backgrounds. The 14 patents that Dr. Carter held for cancer treatment. Innovations had generated millions of dollars in licensing fees, but rather than pursuing personal wealth, she had used these funds to establish research foundations and treatment programs specifically designed to serve under-resourced communities. Her approach to medical innovation was shaped by her understanding that scientific advancement meant nothing if it didn't translate into better health outcomes for the people who needed help most desperately. Michael Harrison's preparation for the interview had included reviewing budget documents and interviewing city council members who questioned the effectiveness of community health spending, but it had not included any research into Dr. Carter's background, professional accomplishments, or the specific services provided by her clinic. His approach to investigative journalism emphasized confrontation and gotcha moments designed to expose hypocrisy or waste, rather than the kind of comprehensive reporting that sought to understand complex issues from multiple perspectives. The morning show format that Harrison had developed emphasized rapid-fire questioning and adversarial interviewing techniques that were designed to unbalance guests and elicit defensive responses that could be edited into compelling television. His success in exposing political corruption and corporate malfeasance had established his reputation as an aggressive journalist who wasn't afraid to ask tough questions, but it had also created a professional persona that prioritized dramatic confrontation over nuanced understanding. Dr. Carter's agreement to appear on Harrison's show had been motivated by her concern that budget cuts would force the closure of programs that provided essential services to vulnerable populations. Her experience with media interviews was limited to occasional appearances at medical conferences and academic symposiums, environments where discussion focused on research findings and clinical outcomes rather than political conflict and budget controversies. The waiting area where Dr. Carter sat while preparing for her interview was designed to create an atmosphere of nervous anticipation for guests who were about to face Harrison's interrogation. The stark white walls, uncomfortable plastic chairs, and prominently displayed television monitors showing clips from previous confrontational interviews were intended to establish Harrison's dominance and suggest that guests were entering hostile territory where they would be held accountable for their positions and decisions. Dr. Carter's calm demeanor while waiting for her interview reflected both her professional experience in high-pressure medical situations and her confidence in the value and importance of the work she had dedicated her life to advancing. Her worn leather briefcase contained documentation of every life saved, every breakthrough achieved, and every community served through the programs that Harrison's investigation sought to characterize as wasteful government spending. The irony of the situation was profound, but invisible to everyone except Dr. Carter herself. The journalist who was preparing to attack her for allegedly wasting taxpayer money had no idea that he was about to confront someone whose medical innovations had generated more economic value through improved health outcomes than any other single individual in the city's history. Her cancer treatment protocols alone had extended thousands of lives and prevented millions of dollars in end-of-life care costs, while her community health initiatives had reduced emergency room usage and prevented countless expensive medical crises through early intervention and preventive care. The production assistant who escorted Dr. Carter from the waiting area to the studio set treated her with the polite but dismissive courtesy typically reserved for guests who were expected to provide content for hostile interviews rather than meaningful dialogue. The young woman's instructions about microphone placement and camera positions were delivered in the tone used for people who were not expected to be familiar with television production or sophisticated enough to understand media strategy. As Dr. Carter settled into the guest chair across from Harrison's imposing desk, she noticed the carefully arranged props that surrounded the set: enlarged budget documents highlighting healthcare spending, graphs showing cost increases over time, and photographs of the community health clinic that emphasized its modest facilities rather than the life-saving services provided within those walls. The visual elements were clearly designed to support a narrative about waste and inefficiency, rather than one about compassion and effectiveness. Harrison's approach to beginning the interview was calculated to establish his authority and place Dr. Carter in a defensive position from the very first moment. His opening statement was designed not as a question, but as an accusation that would force her to justify her existence and defend programs that he had already characterized as problematic in his introduction to the segment. Dr. Carter, taxpayers in this city are spending $2 million a year on healthcare programs that serve a tiny fraction of our population, Harrison began, his tone conveying skepticism and disapproval before she had spoken a single word. How do you justify asking hard-working families to subsidize medical care for people who should be taking responsibility for their own health and financial situations? The question revealed Harrison's fundamental misunderstanding of both healthcare economics and the nature of community health interventions, but it also demonstrated his commitment to the confrontational approach that had made his show popular among viewers who enjoyed watching public figures being challenged and embarrassed on television. His assumption that Dr. Carter would be flustered or defensive reflected his experience with politicians and bureaucrats who typically appeared on his show, rather than medical professionals who were accustomed to making life-and-death decisions under pressure. Dr. Carter's response to Harrison's aggressive opening was informed by 53 years of explaining complex medical concepts to patients, families, and colleagues who needed to understand both the immediate implications and long-term consequences of healthcare decisions. Her calm, measured tone reflected her professional training and her confidence in the facts and evidence that supported every program she had developed. Mr. Harrison, I appreciate the opportunity to discuss the vital healthcare services that our community clinic provides, Dr. Carter replied, her voice carrying the quiet authority that had commanded respect in operating rooms and medical conferences for decades. Before we discuss costs, I think it would be helpful to review the health outcomes and economic benefits that these programs have generated for our entire community over the past 35 years. Harrison's response to Dr. Carter's measured reply revealed his commitment to the adversarial interview style that had made his show popular among viewers, who enjoyed watching authority figures being challenged, but it also demonstrated his complete lack of preparation for engaging with someone whose expertise and accomplishments far exceeded his understanding. Dr. Carter, that sounds like the kind of bureaucratic double talk that taxpayers are tired of hearing, Harrison interrupted, his tone designed to dismiss her attempt to provide context. We're not here to discuss theoretical benefits. We're here to talk about real money being spent on programs that most people in this city will never use. The interruption and dismissal transported Dr. Carter back to 1968, when she was presenting her groundbreaking research on racial disparities in cancer survival rates at a medical conference in Birmingham, Alabama. A senior physician, a white man about Harrison's age, had interrupted her presentation with almost identical language, dismissing her carefully documented findings as theoretical speculation and suggesting that resources would be better spent on practical medicine rather than social activism disguised as research. That moment in Birmingham had been a turning point in Dr. Carter's career, not because it discouraged her from pursuing research that challenged conventional wisdom, but because it taught her that the most important discoveries often emerged from questions that others were unwilling to ask, or investigations that others deemed unnecessary. The cancer treatment protocols that would eventually save thousands of lives had been developed precisely because she had refused to accept that disparate health outcomes were inevitable or acceptable. The revolutionary cancer research that established Dr. Carter's international reputation began with a simple observation during her residency at Johns Hopkins. Black patients with aggressive lung cancers seemed to respond differently to standard chemotherapy regimens than white patients with similar diagnoses, but the medical literature contained no studies that examined whether genetic variations might influence treatment effectiveness across different populations. Her decision to investigate these treatment disparities required her to challenge fundamental assumptions about cancer biology and to design research studies that most senior physicians considered unnecessary or potentially controversial. The prevailing medical wisdom of the 1960s emphasized universal treatment protocols based on tumor type and staging, without consideration of how genetic background might influence drug metabolism or cellular response to therapeutic interventions. The 5 years of research that Dr. Carter conducted while completing her oncology fellowship required her to work essentially 2 full-time jobs, providing clinical care for cancer patients during regular hospital hours and conducting laboratory research during evenings and weekends. Her investigation involved analyzing tissue samples from over 3,000 patients, developing new laboratory techniques for measuring cellular response to chemotherapy drugs, and collaborating with geneticists and biochemists who were just beginning to understand how hereditary factors influence disease progression and treatment outcomes. The breakthrough discoveries that emerged from Dr. Carter's research fundamentally changed how oncologists approached cancer treatment for patients of all backgrounds. Her work demonstrated that genetic variations in enzyme production affected how quickly different populations metabolized certain chemotherapy drugs, leading to the development of personalized dosing protocols that improved survival rates while reducing toxic side effects. The clinical trials that tested her modified treatment approaches showed 20 to 30% improvements in 5-year survival rates for several types of aggressive cancers. The 14 patents that Dr. Carter ultimately received for her cancer treatment innovations represented not just scientific achievement, but also a philosophical approach to medical research that prioritized patient outcomes over profit margins. Rather than licensing her discoveries exclusively to pharmaceutical companies that would maximize revenue through high drug prices, she structured licensing agreements that ensured affordable access to improved treatments while generating funding for additional research and community health programs. The economic impact of Dr. Carter's medical innovations extended far beyond the immediate benefits to cancer patients and their families. Health economists who studied the long-term effects of her treatment protocols estimated that her discoveries had prevented over 40,000 premature deaths and had reduced healthcare costs by more than $800 million through improved cure rates and reduced need for expensive end-of-life interventions. Harrison's journalistic investigation into healthcare spending had focused exclusively on annual budget allocations and administrative costs, without any analysis of health outcomes, mortality prevention, or the broader economic benefits of medical interventions. His approach to evaluating healthcare programs was similar to assessing the value of fire departments based solely on the cost of fire trucks and firefighter salaries, without considering the property damage and lives saved through fire prevention and emergency response services. The community health clinic that Dr. Carter had established in 1987 represented her understanding that medical breakthroughs meant nothing if they couldn't reach the patients who needed them most desperately. Located in a neighborhood where the nearest hospital was 12 miles away and where most residents relied on emergency rooms for primary care, the clinic provided services that ranged from routine checkups and immunizations to specialized cancer screenings and chronic disease management. The funding model that sustained the clinic's operations reflected Dr. Carter's innovative approach to healthcare delivery and her understanding that community health represented an investment rather than an expense. Federal grants provided baseline operational support, but the clinic's expanded services were funded through a combination of patent licensing revenues, donations from grateful patients and their families, and volunteer contributions from retired medical professionals who shared Dr. Carter's commitment to healthcare equity. The volunteer network that supported the clinic's operations included over 200 retired physicians, nurses, pharmacists, and medical technicians who donated their time and expertise to ensure that patients received the same quality of care available in the city's most expensive private hospitals. Dr. Carter's reputation in the medical community and her personal relationships with colleagues she had worked with throughout her career enabled her to recruit volunteers whose combined experience represented thousands of years of medical practice and research. The cancer screening program that the clinic provided had identified over 1,500 cases of early-stage cancers that might otherwise have gone undetected until they had progressed to advanced, often terminal stages. The early detection and treatment of these cancers had not only saved lives, but had also prevented the enormous costs associated with end-stage cancer care, which could easily exceed $200,000 per patient for experimental treatments and intensive care interventions. Harrison's preparation for the interview had included reviewing budget documents provided by city councillors who questioned healthcare spending, but it had not included any research into the specific services provided by Dr. Carter's clinic or the health outcomes achieved through community-based medical interventions. His approach to investigative journalism emphasized finding problems and exposing waste, rather than understanding complex systems or evaluating long-term effectiveness. The morning show format that Harrison had developed prioritized dramatic confrontation and adversarial questioning over informational content or educational value. His interviews were designed to create compelling television through conflict and controversy, rather than to provide viewers with comprehensive understanding of important issues. The success of his show was measured by audience ratings and social media engagement, rather than by the accuracy or usefulness of the information presented. Dr. Carter's decades of experience in medical education and patient communication had prepared her to explain complex concepts in ways that non-medical audiences could understand, but it had not prepared her for the kind of hostile interrogation that prioritized entertainment value over factual accuracy. Her approach to professional communication emphasized respect, collaboration, and evidence-based discussion rather than the adversarial dynamics that characterized television journalism. Mr. Harrison, I understand your concern about fiscal responsibility, Dr. Carter continued, maintaining her professional composure despite the obvious hostility in Harrison's approach. However, evaluating healthcare programs solely based on annual costs without considering health outcomes and long-term economic benefits is like judging the value of education by the cost of textbooks without measuring whether students actually learn to read. The analogy that Dr. Carter offered was designed to help Harrison and his viewers understand the fundamental error in approaching healthcare as a simple cost-cutting exercise rather than as an investment in community well-being and economic stability. Her comparison drew on concepts that were familiar to most people while illustrating the complex relationship between immediate expenditures and long-term benefits. Harrison's reaction to Dr. Carter's attempt to provide educational context revealed his commitment to maintaining control over the interview narrative and his determination to portray her as an out-of-touch advocate for wasteful spending rather than as a medical expert with relevant knowledge and experience. Dr. Carter, taxpayers don't need lectures about healthcare theory, Harrison replied, his voice taking on the condescending tone that he typically used when dismissing guests who attempted to challenge his framing of issues. They need to know why their hard-earned money is being spent on programs that benefit a small number of people, instead of being returned to them through tax cuts or spent on services that benefit everyone. The false dichotomy that Harrison presented between healthcare spending and tax relief reflected his fundamental misunderstanding of how public health investments benefited entire communities rather than just individual patients. His suggestion that healthcare programs only benefited a small number of people ignored the broader economic and social benefits of disease prevention, early intervention, and community health improvement. Dr. Carter's response to Harrison's continued hostility was informed by her understanding that this interview represented an opportunity to educate not just the journalist, but also the television audience about the value and importance of community health programs. Her decision about how to respond would determine whether this confrontation became a learning experience or simply another example of media sensationalism triumphing over substantive discussion. If this story is touching your heart, tell us in the comments where you're watching from. And if you're not subscribed yet, now's the time. Mr. Harrison, I think there might be some confusion about who benefits from community health programs, Dr. Carter said, her voice remaining calm and educational despite the increasingly hostile environment. When we prevent cancer deaths through early screening, when we manage diabetes and hypertension to prevent heart attacks and strokes, and when we provide immunizations that prevent disease outbreaks, We're protecting the health and economic well-being of the entire community, not just individual patients. The explanation that Dr. Carter provided illustrated the interconnected nature of public health and the ways that investments in community healthcare created benefits that extended far beyond the immediate recipients of medical services. Her approach to explaining these concepts reflected decades of experience in medical education and her understanding that complex ideas required careful explanation and concrete examples to be understood by non-specialist audiences. Harrison's response to Dr. Carter's patient explanation revealed his determination to maintain the adversarial tone that made for compelling television, even when faced with information that challenged his fundamental assumptions about healthcare spending and community benefit. Dr. Carter, that sounds like exactly the kind of justification that bureaucrats always use when they're caught wasting taxpayer money, he said, leaning forward in his chair with the aggressive posture that had become his signature interviewing style. Let's talk about specific numbers. Your clinic serves maybe 500 people a year, but it costs taxpayers $2 million. That's $4,000 per person, more than most families spend on healthcare for their entire family. The mathematical calculation that Harrison presented was technically accurate, but fundamentally misleading, reflecting his complete misunderstanding of how healthcare economics worked and his failure to account for the broader community benefits generated by disease prevention and early intervention programs. His cost-per-patient analysis was equivalent to evaluating the effectiveness of vaccination programs based only on the number of people who received shots, without considering the thousands of additional people who benefited from herd immunity and disease prevention. Dr. Carter's response to Harrison's misleading statistics was informed by decades of experience in presenting complex medical data to hospital administrators, insurance executives, and government officials who often approached healthcare from purely financial perspectives without understanding the clinical and epidemiological factors that determined program effectiveness. Mr. Harrison, your calculation illustrates exactly why healthcare programs can't be evaluated using simple division. Dr. Carter replied, her voice maintaining its educational tone despite the increasingly hostile environment. When our clinic identifies and treats a case of tuberculosis before it spreads through the community, we're protecting hundreds of people who will never need treatment because they were never exposed. When we provide diabetes management that prevents a heart attack, we're saving not just one life, but also the $200,000 that emergency cardiac surgery would cost. The examples that Dr. Carter provided were drawn from actual cases documented in her clinic's files, but Harrison's journalistic training had not prepared him to understand the difference between direct service delivery and community health protection. His approach to investigative reporting emphasized finding waste and exposing problems rather than understanding complex systems or evaluating long-term effectiveness. Harrison's escalating frustration with Dr. Carter's refusal to accept his framing of the issue prompted him to adopt an even more aggressive approach, one that revealed both his professional arrogance and his complete ignorance of the person he was attempting to intimidate. Dr. Carter, you can throw around all the medical jargon you want, but the bottom line is that you're running a charity operation on taxpayer money, he said, his voice taking on the contemptuous tone that he typically reserved for politicians caught in scandals. You're basically asking working families to subsidize healthcare for people who should be taking responsibility for their own medical bills. The characterization of Dr. Carter's work as charity and medical jargon revealed Harrison's fundamental misunderstanding of both the nature of her accomplishments and the sophistication of the programs she had developed. His suggestion that patients should take responsibility for medical costs ignored the economic realities faced by working families and the systemic barriers that prevented many people from accessing affordable health care. Dr. Carter's decision about how to respond to Harrison's escalating hostility was informed by her understanding that this moment represented more than just a disagreement about healthcare policy. It was an opportunity to educate the public about the value of medical research and community health programs while demonstrating the dignity and professionalism that had characterized her entire career. Mr. Harrison, I think there might be some misunderstanding about the nature of the work we do at the clinic and my background in medical research, Doctor, Carter said, reaching into her worn leather briefcase to retrieve documentation that would transform the interview from an attack on healthcare spending into a revelation about one of the most accomplished medical professionals in the city's history. The documents that Dr. Carter withdrew from her briefcase included copies of her 14 medical patents, reprints of research papers published in the world's most prestigious medical journals, and letters of recognition from organizations including the American Cancer Society, the National Institutes of Health, and the World Health Organization. The weight of her accomplishments was literally in her hands, but Harrison had been so focused on his predetermined narrative that he had never bothered to research the background of the woman he was preparing to publicly humiliate. Mr. Harrison, before we continue discussing healthcare costs, I think it would be helpful for you and your viewers to understand what qualifies me to speak about community health programs. Dr. Carter continued, her voice taking on the authoritative tone that had commanded respect in medical conferences around the world. I'm not just an administrator running a clinic. I'm a cancer researcher whose work has directly saved thousands of lives and whose innovations have been implemented in hospitals throughout the United States and internationally. The revelation of Dr. Carter's true credentials began to shift the dynamic of the interview in ways that Harrison was completely unprepared to handle. His investigative background had involved confronting politicians and bureaucrats who were typically defensive about their positions and uncomfortable with aggressive questioning. He had never encountered someone whose professional accomplishments were so substantial that his attacks only served to highlight his own ignorance and inadequate preparation. The first document that Dr. Carter placed on Harrison's desk was a letter from the director of the National Cancer Institute, acknowledging her contributions to improving survival rates for patients with aggressive lung cancers. The letter, dated just 6 months earlier, described her treatment protocols as revolutionary and credited her research with preventing an estimated 12,000 cancer deaths over the past decade alone. Harrison's reaction to seeing official correspondence from the federal government's premier cancer research institution revealed his growing awareness that he had completely misjudged both the nature of Dr. Carter's work and her standing in the medical community. His attempt to maintain his adversarial approach became increasingly awkward as evidence mounted that he was attacking someone whose expertise and accomplishments far exceeded his understanding. That's very impressive, Dr. Carter, Harrison stammered, his professional composure beginning to crack as he processed the implications of the documents she was presenting. But we're not here to discuss your research. We're here to talk about taxpayer funding for community health programs. Dr. Carter's response to Harrison's attempt to dismiss her credentials demonstrated both her professional experience in dealing with skeptical audiences and her understanding that education required persistence and patience, especially when confronting willful ignorance or predetermined conclusions. Mr. Harrison, my research and the community clinic are directly connected, Dr. Carter explained, her voice remaining calm and educational despite Harrison's obvious discomfort. The cancer screening protocols we use at the clinic are based on the same research that has improved survival rates in major medical centers around the world. The difference is that our clinic makes these life-saving innovations available to patients who couldn't otherwise afford them. The connection that Dr. Carter drew between her internationally recognized research and the community health programs that Harrison was attacking illustrated the sophisticated approach she had developed to translating medical breakthroughs into practical interventions that served under-resourced populations. Her explanation revealed that the clinic wasn't just providing basic health care, it was delivering cutting-edge medical innovations to patients who had been abandoned by the traditional healthcare system. The second document that Dr. Carter presented was a research paper published in the New England Journal of Medicine documenting the effectiveness of her cancer treatment protocols. The paper, which had been cited over 3,000 times by other researchers, described clinical trials showing that her modified chemotherapy regimens improved 5-year survival rates by an average of 28%, while reducing toxic side effects that often forced patients to discontinue treatment. Harrison's growing understanding that he was confronting one of the world's leading cancer researchers, rather than a local healthcare administrator, prompted him to attempt a different approach to the interview, but his lack of scientific background and his commitment to the confrontational style that had made his show popular prevented him from effectively engaging with the substance of Dr. Carter's work. Dr. Carter, I'm sure your research is very important, Harrison said, his tone becoming slightly less aggressive as he processed the magnitude of her accomplishments. But the question remains whether taxpayers should be funding programs that serve such a small percentage of the population when that money could be used for services that benefit everyone. The persistence of Harrison's misunderstanding about community health benefits, even when confronted with evidence of Dr. Carter's expertise and achievements, revealed the depth of his ideological commitment to a narrative that portrayed government healthcare spending as wasteful rather than as investment in community well-being. Dr. Carter's response to Harrison's continued focus on narrow cost calculations was informed by her understanding that this interview represented an opportunity to educate not just an ignorant journalist, but also a television audience that might be similarly misinformed about the value and effectiveness of community health programs. Mr. Harrison, I think the real question is whether we can afford not to invest in community health programs, Dr. Carter said, her voice carrying the authority that came from 5 decades of seeing healthcare policy decisions play out in terms of human lives saved or lost. When a community fails to provide accessible healthcare, when people delay treatment because they can't afford it, when preventable diseases go undetected until they become medical emergencies, the costs to everyone, through higher insurance premiums, overwhelmed emergency rooms, and lost productivity, far exceed the investment required for prevention and early intervention. The comprehensive explanation that Dr. Carter provided illustrated her deep understanding of healthcare economics and her ability to articulate complex concepts in ways that non-medical audiences could comprehend. Her approach to education reflected decades of experience in medical training and her commitment to ensuring that important information reached people who needed to understand it. The third document that Dr. Carter presented was a cost-effectiveness analysis conducted by health economists at the State University, showing that every dollar invested in her clinic's programs generated an average of $7 in savings through reduced emergency room usage, decreased hospitalization rates, and prevention of expensive medical complications. Harrison's examination of the economic analysis revealed data that directly contradicted his assumption that community health programs represented wasteful spending rather than cost-effective investment. His growing awareness that his investigative report was based on incomplete information and flawed analysis prompted him to attempt one final attack on Dr. Carter's credibility and the value of her work. Harrison's final attempt to salvage his investigation and maintain his adversarial position revealed the depth of his professional arrogance and his unwillingness to acknowledge that his entire premise had been fundamentally wrong from the beginning. Dr. Carter, I don't care how many awards you've won or how many papers you've published, he said, his voice taking on a desperate edge as he realized that his carefully planned exposé was collapsing in front of a live television audience. The fact remains that you're using taxpayer money to run programs that most people in this city will never benefit from, and you're asking hard-working families to pay for medical care that should be the responsibility of patients themselves. The attack was both personally insulting and professionally devastating for Harrison, revealing his complete inability to process new information or adjust his conclusions when presented with evidence that contradicted his predetermined narrative. His dismissal of Dr. Carter's awards and papers demonstrated that he had no understanding of the significance of her accomplishments or the respect she commanded within the international medical community. Dr. Carter's response to Harrison's final assault was informed by her understanding that this moment represented more than just a disagreement about healthcare policy. It was an opportunity to demonstrate the dignity, professionalism, and grace that had characterized her entire career while educating the public about the true value of medical research and community service. Mr. Harrison, I can see that you're committed to a particular narrative about healthcare spending, but I think your viewers deserve to understand the full scope of what we're discussing, Dr. Carter said, her voice remaining calm and authoritative despite the obvious hostility she was facing. She reached into her briefcase one final time and withdrew a leather portfolio that contained documentation of accomplishments that would transform not only Harrison's understanding, but also the perspective of everyone watching the interview. The portfolio that Dr. Carter opened contained her medical school diploma from Harvard University, where she had graduated magna cum laude in 1968 as one of only 3 black women in her class. It included her residency completion certificate from Johns Hopkins University, documentation of her board certifications in internal medicine and oncology, and records of her appointments as Chief of Oncology at Metropolitan General Hospital, Professor Emeritus at the State Medical School, and visiting scholar at research institutions in 12 countries. Mr. Harrison, since you've dismissed my research achievements, perhaps you'd like to know about my educational background and professional experience, Dr. Carter continued, her tone taking on the authority that had commanded respect in medical conferences and hospital boardrooms for over 5 decades. I graduated from Harvard Medical School in 1968, completed my residency at Johns Hopkins, and spent the next 53 years practicing medicine, conducting research, and training the next generation of physicians who are now saving lives in hospitals around the world. The revelation of Dr. Carter's credentials created a moment of stunned silence in the television studio as Harrison, his production team, and the viewing audience began to process the magnitude of the accomplishments belonging to the woman he had been attacking for the past 15 minutes. The contrast between his dismissive treatment and her actual qualifications was so stark that it began to transform the interview from a journalistic investigation into a public humiliation of the journalist himself. The next document that Dr. Carter presented was a letter from the president of the American Medical Association acknowledging her lifetime contributions to cancer research and her role in developing treatment protocols that had been adopted by oncology programs throughout North America and Europe. The letter, signed by representatives of medical organizations from 43 countries, described her work as transformational and credited her innovations with fundamentally changing how the medical profession approaches cancer treatment for patients of all backgrounds. Harrison's reaction to seeing official recognition from the most prestigious medical organizations in the world revealed his growing understanding that he had not simply made an error in judgment, he had committed professional suicide on live television by attacking someone whose reputation and accomplishments far exceeded anything he might achieve in his entire journalism career. Dr. Carter, I had no idea about your background, Harrison stammered, his professional composure completely shattered as he realized that every assumption he had made and every attack he had launched had been directed at one of the most distinguished medical professionals in the country. I mean, my research focused on budget documents and cost analysis, not on the specific qualifications of program administrators. The admission that Harrison's research had been limited to budget documents without any investigation into the background, qualifications, or achievements of the people running the programs he was criticizing revealed the superficial and irresponsible nature of his journalism. His characterization of Dr. Carter as a program administrator rather than a world-renowned cancer researcher demonstrated the depth of his ignorance and the inadequacy of his preparation. Dr. Carter's response to Harrison's stammering apology was shaped by her decades of experience in medical education and her understanding that moments of professional failure could become opportunities for learning and growth if handled with wisdom and compassion rather than vindictiveness and punishment. Mr. Harrison, I understand that investigative journalism requires asking difficult questions about how public funds are used, Dr. Carter said, her voice taking on the teaching tone that had guided thousands of medical students and residents through their training. but I hope this conversation illustrates the importance of understanding what you're investigating before you draw conclusions about its value or effectiveness. The educational approach that Dr. Carter took toward Harrison's professional humiliation reflected her lifelong commitment to teaching and her understanding that public discourse was improved when people were willing to learn from their mistakes rather than simply being punished for them. Her response demonstrated the same grace and dignity that had enabled her to overcome decades of discrimination and professional challenges while building a career that saved thousands of lives. The final document that Dr. Carter presented was a collection of letters from patients and their families, thanking her for medical care that had extended their lives, for research that had made effective treatments possible, and for community health programs that had provided access to care when no other options existed. The letters, written over a span of 30 years, told stories of cancer survivors who had lived to see their children graduate from college, of grandparents who had been present for wedding celebrations, and of community members whose lives had been fundamentally changed by access to quality healthcare. Mr. Harrison, these letters represent the real measure of effectiveness for community health programs, Dr. Carter said, her voice carrying the emotion that came from reading grateful words from people whose lives had been saved or extended through her work. When you ask whether taxpayers should fund these programs, you're really asking whether we believe that every person deserves access to the same quality of medical care, regardless of their economic circumstances. The human impact of Dr. Carter's work, documented in handwritten letters from grateful patients and families, created a stark contrast with Harrison's cold calculation of cost per patient served. The stories contained in those letters illustrated the difference between understanding healthcare as a business transaction and understanding it as a fundamental human need that civilized societies had a responsibility to address. Harrison's attempt to respond to Dr. Carter's presentation of patient testimonials revealed his complete inability to process the transformation that had occurred during the interview. What had begun as his investigation into wasteful government spending had become a revelation about one of the most accomplished medical professionals in the city, whose work had saved thousands of lives and whose innovations had been implemented in hospitals around the world. Dr. Carter, I think there's been a serious misunderstanding here, Harrison said, his voice reflecting both embarrassment and growing awareness of the professional damage he had inflicted on himself through his unprepared and prejudicial approach to the interview. I clearly didn't have adequate information about your background or the full scope of the programs you've developed. The admission that he had conducted an investigation without adequate information revealed the irresponsible nature of Harrison's journalism and his willingness to attack people and programs based on incomplete understanding and predetermined conclusions. His acknowledgement of serious misunderstanding was actually an acknowledgement of serious professional failure that would have lasting consequences for his credibility and career. Dr. Carter's final statement in the interview reflected her understanding that this moment represented an opportunity to educate not just Harrison, but also the television audience about the value of community health programs and the importance of supporting medical research and care for underserved populations. Mr. Harrison, I hope that people watching this interview will understand that community health programs represent investments in all of our well-being, Dr. Carter said, her voice carrying the authority and wisdom that came from a lifetime dedicated to healing and service. When we ensure that every person has access to quality healthcare, when we support research that leads to better treatments, and when we build systems that serve everyone regardless of their ability to pay, we create stronger, healthier communities that benefit all of us. If this story moved you, don't stop here. Click the next one, subscribe, and share this with someone who still believes in kindness. The interview concluded with Harrison's mumbled thanks and Dr. Carter's dignified departure from the studio, but the impact of their confrontation extended far beyond the television program to influence public understanding of healthcare policy and professional journalism standards. The video of Harrison's humiliation went viral within hours, viewed millions of times by people who were amazed by Dr. Carter's grace under pressure and appalled by the journalist's unprepared and prejudicial attack on someone whose accomplishments far exceeded his understanding. 6 months after the interview that ended his career at Channel 8 News, Michael Harrison was working as a freelance writer for local publications, having learned through painful public humiliation the importance of thorough research and respectful interviewing techniques. His experience with Dr. Carter had taught him that assumptions based on appearance or predetermined narratives could lead to catastrophic professional failure when confronted with people whose stories and accomplishments challenged conventional expectations. Dr. Carter's handling of Harrison's attack became a case study in crisis communication and professional dignity, used in journalism schools and medical ethics courses to illustrate both the importance of thorough research and the power of responding to hostility with education rather than retaliation. Her demonstration that expertise and accomplishment could triumph over ignorance and prejudice inspired countless viewers who had faced similar discrimination or dismissal based on their appearance, age, or background. The community health clinic that Harrison had attacked as wasteful government spending received an unprecedented increase in funding and volunteer support following the interview, as viewers who had witnessed Dr. Carter's grace and learned about her accomplishments wanted to support programs that embodied her values of service and excellence. The clinic became a model for community health delivery that was studied and replicated in cities across the country. The elderly black woman who had been attacked on live television for allegedly wasting taxpayer money had used that moment of injustice to educate the public about the true value of medical research and community service. Her response to professional hostility had demonstrated that the most powerful response to ignorance was not anger or retaliation, but patient education and the kind of dignity that transforms attackers into students and obstacles into opportunities for growth.